Cystic fibrosis is a disease of Caucasian population, Western population, European population. Do we have cystic fibrosis in our country? Do we have cystic fibrosis in our country? It was 2013. A 7-year-old child with a recurrent wheezing, failure to thrive, clubbing, presented with bronchiectasis. Her name is Madhu. She is right now around 18 years old, I think. That was our first case of cystic fibrosis. Till then, we have discovered around 65 cases of cystic fibrosis in our center. In Tamil Nadu, there are around 500 cystic fibrosis cases. So, what do you mean by that? We have cystic fibrosis in each and every corner of Tamil Nadu also, wherever you live. It is there in each and every part of our country, not only country, many parts of the world. Cystic fibrosis is not anymore a Caucasian or Western population disease. It is as common as your tuberculosis, right? So, when I should diagnose, when I should consider cystic fibrosis as a cause, and what is the pathophysiology behind it, we are going to discuss in this first session right now. Look at this child with frank failure to thrive, with skin and bones, along with the multiple lung infiltrates and collapse, brought to us in the year 2015. His name is Kadir. Mother also lost her first child. Mother lost her first child. Okay. So what happened? When the child came to us, initially we were thinking in terms of primary immunodeficiency. We were looking in terms of severe combined immunodeficiency. But look here. The sodium is 129. The sodium is 129. Look at this. Sodium is 129. Potassium is 2.7. Any child with, along with, look here, minimally deranged OTPT. What next? When we took ABG, look here, alkalosis, pH more than 7.61. The bicarbonate is 48.6. So metabolic alkalosis, there is hypoxia. But beyond that, look here, I have hyponatremia, hypokalemia, hypochloremia, real case. So what is this? Whenever you see any child with pneumonia, lung infiltrates, along with the hyponatremia, hypochloremia, hypokalemia, metabolic alkalosis, with or without a deranged OTPT, you need to consider cystic fibrosis in our country too. Right? So when to diagnose cystic fibrosis? Right now you need to consider cystic fibrosis even from antenatal period if mother shows echogenic bowel. Antenatal ultrasound, the thick meconium in the bowel can produce echogenic bowel. So any mother who is brought with the echogenic bowel, you need to suspect cystic fibrosis in that child even from antenatal period. And any child who is brought with intestinal obstruction in the newborn period due to meconiumelia should be suspected for cystic fibrosis unless otherwise proved. Unexplained respiratory distress, neonatal respiratory distress could be due to cystic fibrosis or primary or primary ciliary dyskinesia. Recently, we have seen a surge of 5 newborns and early infants presenting with neonatal cholestasis, mildly deranged LFT. When they investigated for galactosemia, what is that, von Gierke disease, tyrosinemia, everything turned out to be normal, but the child finally turned out to be cystic fibrosis. Neonatal cholestasis or prolonged jaundice is also a manifestation of cystic fibrosis because of the ductal obstruction by the thick mucus. As I told you, any child with unexplained respiratory distress, normal echo, term child, rule out CF. Late onset hemorrhagic disease of newborn. Why? Cystic fibrosis is more often associated with, not all, but more often associated with the pancreatic insufficiency. So the manifestations will be deficiency of A, D, E and K. The dramatic manifestation of vitamin K deficiency is late onset hemorrhagic disease of newborn with intracranial hemorrhage. The child would have got some previous admission for pneumonia. You would have treated the child with broad spectrum antibiotic and discharge. So at present, when the child is admitted with the intracranial hemorrhage, bulging AF, you must be thinking that the child is having that broad spectrum antibiotic given in the previous admission has led to vitamin K deficiency and presenting with intracranial hemorrhage. At present, it is not so. That admission could be due to pseudomonas of CF, and this admission is due to deficiency of fat soluble vitamins because of the presence of oily stools and pancreatic insufficiency. Okay. Cystic fibrosis usually involves upper lobe. It doesn't mean that upper lobe only. Usually starts with the upper lobe bronchiectasis. Summer dehydration. What do you mean by this summer dehydration? Any child who is brought with severe dehydration with hyponatremia, hypochloremia, without much of vomiting or diarrhea. So you need to suspect that chloride and sodium is lost somewhere else, not in vomiting, not in diarrhea. So it must be in sweat, in the absence of polyuria. So any child who is brought to your clinic with severe dehydration, particularly during summer, without much vomiting or loose stools, please suspect cystic fibrosis, my dear friends. As I told you, any pneumonia with hyponatremic, hypochloremic, hypokalemic, metabolic alkalosis resembling Bartter syndrome. Bartter syndrome is a disease of renal tubular defects involving ascending limb of loop of Henle that is associated with polyuria. Any child with Bartter-like manifestations such as hyponatremia, hypochloremia, hypokalemia, metabolic alkalosis, in the absence of polyuria, please consider cystic fibrosis as one of your differential diagnoses. We have one case in 2017 that the child was admitted with persistent pneumonia involving left upper lobe. The child is not responding to any medications. TB is ruled out. Immunodeficiency is ruled out. I was teaching my student that in any case of recurrent pneumonia or persistent pneumonia, you need to ask the history of oily stools even in the first episode pneumonia. Having heard our conversation, the mother herself offered that their child is having oily stools because the child at the time of admission is 2 years, but the child's weight was borderline lowish, 7.8 kgs. Turned out to be a case of cystic fibrosis delta F508 mutation. Exaggerated aquagenic wrinkling. I am going to show you a demonstration video of aquagenic wrinkling. But in day-to-day practice, whenever any child who is having failure to thrive, not gaining weight with a recurrent cough and cold, not to the extent of getting admitted, you can ask one simple question. Amma, while taking food, while playing in a bathroom, while playing in the bucket of water, whether your child gets exaggerated wrinkling of palms and soles, it is a manifestation of cystic fibrosis. It doesn't mean that you need to do in your ward. You can just ask the mother. Exaggerated wrinkling of palms and soles while the child is playing in water or while the child is eating can also suggest cystic fibrosis. As I told you already, any persistent or poorly resolving pneumonia, rule out foreign body, TB, cystic fibrosis, PCD, as well as immunodeficiency. And it was already explained that pancreatic insufficiency is a manifestation of many cystic fibrosis. So oily stools is the rule, and you will lose your ADE vitamin. K vitamin can manifest as late onset hemorrhagic disease of newborn, whereas vitamin A deficiency can lead to bite spot, xerophthalmia, or it could be due, or it can manifest as rickets, which is a manifestation of vitamin D deficiency, or an ataxia, which can be due to manifestation of vitamin E, fat soluble vitamin E deficiency. So many manifestations of cystic fibrosis, not only your persistent or recurrent pneumonia or bronchitis involving upper lobe. Rectal prolapse, any child with rectal prolapse or meconium ileus unless otherwise proved cystic fibrosis in India too. I have 3 such children. Recurrent pancreatitis. Cystic fibrosis is an autosomal recessive disease. So you need to have two mutations involved. When one mutation is involved, I repeat, when one mutation is involved, it often leads to recurrent or chronic pancreatitis rather than due to pancreatic insufficiency. And remember, any child whose endotracheal aspirate or ball reveals pseudomonas, you need to rule out cystic fibrosis. Apart from one another disease in which you will get pseudomonas is chronic granulomatous disease. But remember, pseudomonas produces biofilm, difficult to eradicate. Any child with pseudomonas pneumonia should be suspected for cystic fibrosis unless otherwise proved. So look here, not only your cough, not only your bronchiectasis, there are so many direct and indirect manifestations of cystic fibrosis, so that you need to be vigilant as a pediatrician to find out these manifestations so that you can identify the disease and pick up them early. Then these are all the manifestations. What is the pathogenesis and pathophysiology? Cystic fibrosis is an autosomal recessive disease. So 2 mutations should be there to have its manifestations, full-blown manifestations. So what will happen? Cystic fibrosis, CFTR gene is affected. CFTR gene is helpful for chloride secretion into the duct. When CFTR doesn't work, your chloride will not be secreted out. When chloride is secreted out, water will also come up into the lumen because of osmosis. When chloride is not secreted and retained in the cell, water will not be also secreted into the lumen. As a result of which, what will happen? This will happen. An abnormal CFTR lead to abnormal less chloride secretion into the lumen, leading to lead water secretion into the lumen. Then what happens? Your airway surface liquid depletion, so that your cilia will not move properly because of absence of airway surface liquid depletion. This in turn leads to mucus accumulation, biofilm formation, which in turn leads to pseudomonas, Burkholderia colonization. Other bacteria are like pneumococci will also takes place. Stenotrophomonas also takes place, but the most common is pseudomonas. The most dreadful is Burkholderia cepaceae, leading to chronic inflammation, chronic infection, chronic obstruction, and bronchiectasis and end organ damage to the extent of requiring lung transplantation. So the basic pathophysiology is absence of chloride secretion into lumen, absence of water secretion into lumen, leading to poor airway surface liquid, leading to obstruction, infection, destruction of your lung parenchyma. Bilateral diffuse bronchiectasis more involving your upper lobe. So what are all the CFTR genes? There are 6 variations, 6 types of mutation. In type 1, this is with respect to quantity, there is no CFTR at all. There is no CFTR particles at all. No protein at all. Certain mutations are associated with it. Certain mutations are associated with it. So, no, absolutely quantitative defect. No CFTR chloride channel at all produced by the nucleus. What is class 2? In class 2, CFTR molecules are produced, but the trafficking into the Golgi apparatus and trafficking into the cell membrane cannot happen. So there is no traffic at all. Your delta F508 mutation comes under this absence of trafficking. Production is there. Transport to the respective area will not be there. What is class 3 mutation? Class 3 mutation, production is good. Transport is good. But the execution of the protein at the CFTR at the membrane is bad. Okay, production is good, transport is good, but the execution of the work of the CFTR at the apical lumen is not there. So these 3 mutations, no production, no trafficking, no action, all leads to severe forms of cystic fibrosis. All leads to quantitative defect in the chloride CFTR chloride channel. I repeat, class 1, no production, class 2, no transport, class 3, no action. What is class 4? What is class 4? Class 4, the key is inside, but it is opening the door partially. So instead of all chloride moving out into the lumen, only some chlorides are moving into the lumen. So it is a qualitative defect, class 4. So less severe. What is class 5? What is class 5? Class 5, again there is some problem with respect to the stability of the channel, stability of the CFTR gene, class 5. And finally, class 5, stability in the nucleus itself, produced, but stability is lost in the nucleus itself. Whereas class 6, stability is lost in the apical membrane transporter. This also occurs in delta F508. Accelerated destruction of CFTR at the lumen. So as a result of which, whether it is qualitative or quantitative, absence of chloride secretion, absence of water secretion, depletion of airway mucus layer in the lumen, obstruction, infection, bronchiectasis, and concerned organ destruction. Not only bronchiectasis, cirrhosis can occur because of the ductal obstruction of bile duct. Pancreatic insufficiency and pancreatitis due to the obstruction at the level of pancreatic duct. Obstruction at the level of intestinal lumen leading to distal intestinal obstruction. Obstruction in the vas deferens leading to infertility in a female. A simple chloride channel defect leads to havoc in almost all systems involving the body. So the one which is left out here is infertility in boys due to congenital absence of bilateral vas deferens. With this, we will proceed to the next session on how to diagnose cases of cystic fibrosis. Cystic fibrosis children are notorious to develop pseudomonas colonization because of biofilm formation. Apart from that, in her cohort, we have seen so many cases of methicillin resistant Staphylococcus aureus. Very rarely Burkholderia, Cepaceae, Stenotrophomonas, and typical mycobacterial infections. But majority of them are Pseudomonas aeruginosa and Staph aureus. When it gets colonized, it's very difficult to eradicate that carrier state, and the duration of the treatment prolongs, the cost of the treatment prolongs because the drugs are relatively costly that are used in the management of Pseudomonas aeruginosa. Right. First of all, you know what are all the drugs that has to be used in Pseudomonas aeruginosa and what are all the drugs you use in MRSA. But remember, we can't make such kind of statement in infection control. Always, what the patient grows in the previous admission or previous culture, what is the antibiogram of the patient, what is the sensitivity of the patient, what is the sensitivity in your area, that all should be taken into account before considering the treatment. So remember, throat swab is mandatory, cough swab is mandatory before starting an antibiotic. Do not hesitate to do it, stating that it becomes costly. If the child is not going to respond, if you don't give appropriate regimen, then automatically you need to spend a lot. So before starting therapy, kindly do throat swab, culture and sensitivity. Okay, if throat swab, so after sending the throat swab or cough swab culture and sensitivity, you can start the management based on the previous antibiogram and culture results. If you don't have a culture and if it is a mild exacerbation, the child can be treated on an outpatient basis. Drug co-amoxiclav that usually covers MSSA, pneumococcal Haemophilus influenza, non-typable Haemophilus influenza can be given. If there is a growth of Pseudomonas and if the exacerbation is mild based on the previous report, then you can start 2 anti-Pseudomonal drugs. Only 2 drugs that can be given orally are, one is ciprofloxacin, another is cotrimoxazole for a minimum of 2 weeks duration. So in the absence of Pseudomonas, co-amoxiclav, in the presence of Pseudomonas, a combination of ciprofloxacin and cotrimoxazole, provided the previous report shows some good sensitivity to the above drugs. The duration of treatment is 2 weeks. But in case of severe exacerbations, whether it is culture negative or culture positive means a combination of 2 drugs based on the culture and sensitivity. If culture is not available or culture is negative, you need to presume that you are dealing with a case of Pseudomonas and a combination of cefoperazone, sulbactam and amikacin for a minimum duration of 2 to 3 weeks. 1 week after the resolution of the symptoms. I repeat, 1 week after the resolution of symptoms. If after starting this ceftazidime or cefoperazone along with amikacin, if the child becomes well but your culture report says that it is resistant, you don't mind about the in vitro sensitivity pattern. Response to therapy matters a lot compared to in vitro sensitivity or resistant. In fact, the oral therapy that follows after an initial period of improvement can be based on the in vitro sensitivity. Okay. For that, you need to know what are all the drugs that works against Pseudomonas. Ceftriaxone, cefatoxim does not work. The cephalosporins that work against Pseudomonas are ceftazidime, cefoperazone, sulbactam and cefepime. Anti-pseudomonal penicillin, piperazolin tazobactam or ticarcillin clavulanate. Majority of us are used piperazolin tazobactam. Imipenem and meropenem. Majority of us are using meropenem. Aztreonam is available in oral form, IV form as well as inhaled form. Aminoglycosides, amikacin, quinolone, ciprofloxacin or levofloxacin. We are not using ofloxacin. And if sensitivity pattern makes problem a lot, then you need to consider an inky or ponky with polymyxin, colistin and trimethoprim sulfamethoxazole. You need to know that first generation or second generation cephalosporin does not have activity against pseudomonas. The best is the combination of high dose piperazolin tazobactam or cefobirazone sulbactam or ceftazidime amikacin. Ceftazidime along with aminoglycoside is a better combination. If not, a combination of meropenem plus aminoglycosides. Right. First isolation of pseudomonas, eradication therapy. What is that? Eradication therapy. What do you mean by eradication therapy? Following a 2-week regimen for mild cases and 4-week regimen for moderate to severe cases, that child has to undergo eradication therapy. 30 days of tobramycin, 300 mg twice daily, each costs around 300 rupees, so 600 rupees per day. Or inhaled colistin, twice daily for 1 month. Repeat culture. If culture is negative, don't worry. If there is regrowth within 3 months of initial eradication, even when the child is well, you admit the child, give IV antibiotic based on the culture and sensitivity for about 2 weeks, followed by 3 months course of nebulized toba or colistin or aztreonam. You need to rotate in between these two. Okay, in the first 3 months. But if there is a subsequent regrowth of pseudomonas, then instead of 2 weeks of dual therapy, you need to give 4 weeks of dual therapy to start with, followed by every alternative day. First month, for example, tobramycin. Second month, for example, colistin. Third month, for example, aztreonam. You can try. So first eradication 1 month, subsequent eradication requires 3 months, whereas subsequent regrowths after 3 months requires a duration of about 6 months therapy. Again, a combination of aztreonam or colistin or tobramycin. Tobramycin is the commonly used drug. Right. With respect to MRSA, if it is MSSA, co-amoxiclav. If it is MRSA, vancomycin. Well child, oral clindamycin. Ill child, oral vancomycin. Duration of therapy, even in the first instance or second instance, 4 weeks. Remember, first growth 2 drugs, second growth 2 drugs for 4 weeks. If there are 2 or more isolates in 1 year, then you need to give suppressive prophylaxis with flucloxacillin or amoxicillin clavulanate. Right? Rarely do you get stenotrophomonas. Mild cases will benefit from cotrimoxazole. Severe cases will benefit from meropenem. Haemophilus influenza, co-amoxiclav will do wonders in OP case and ceftriaxone or co-amoxiclav in inpatient treatment. AVPU, whenever a child with cystic fibrosis presents with a recurrent wheezing on and off, not responding to Forocard, with a huge hyperinflation or recurrent new onset focal infiltrates, along with the rusty sputum, consider AVPU. Along with the inhaled corticosteroids with the LABA, you need to give oral prednisolone. If not responding, add oral antifungal. If not responding, add omalizumab. Majority of the cases will respond to oral steroids alone along with inhaled corticosteroids and LABA. Again, when the child with cystic fibrosis develop new onset cystic lesion, subacute onset, low-grade fever, mimicking tuberculosis, but AFB positive, CB not negative means you need to suspect atypical mycobacterium infections like abscess, chiloni, kansai, for which a course of clarithromycin, meropenem and aminoglycosides will do wonders rather than ATT. Right? So remember, mild cases, pseudomonas, cotrimoxazole along with the quinolones. Moderate to severe cases, you need to give combination of piperazolone tazobactam or meropenem or ceftazidime along with aminoglycosides. Eradication with tobramycin is must. Regrowth requires two dual eradication with tobramycin or colistin or aztreonam. Subsequent regrowth requires 6 months of prophylaxis therapy. Staphylococcus aureus, vancomycin or clindamycin or coamoxiclav. 2-drug therapy in case if the child becomes ill. Total duration of therapy 4 weeks. Suppressive prophylaxis is indicated when 2 or more times the child develops MRSA with either cotrimoxazole, flucloxacillin or cotrimoxazole or coamoxiclav. AFB positive, TB like symptoms, CB not negative, please consider atypical mycobacterial infections. Infection control is the cornerstone apart from chest physiotherapy and enzyme replacement therapy in children with cystic fibrosis. Other complications that you need to know with respect to cystic fibrosis are distal intestinal obstruction, hepatobiliary disease, sinusitis, nasal polyp, hemoptysis, and whether the child is going to require oxygen therapy at home. When you need to consider this distal intestinal obstruction, when any child is brought with right lower abdominal pain, a child is brought with constipation, a child with a palpable mass in the right lower iliac fossa, then you need to consider distal intestinal obstruction. This occurs particularly in the presence of a child who had meconium ileus at birth and along with that the child had severe fatty malabsorption. In those instances, distal intestinal obstruction is more common. You take an X-ray to rule out other mimics. You take an ultrasound to rule out other mimics like what is that? To rule out other mimics like cholangitis, appendicitis, etc. Pancreatitis, because cholangitis, pancreatitis, appendicitis, intussusception is also common in DIOS. But in those instances, the child will be sick, but here the child will not be sick. X-ray may show intestinal fluid levels and ileocecal mass. Treatment is primarily hydration. Hydrate the patient first, either IV or oral. You can try laxatives. You can try polyethylene glycol. If not, admit the patient and give gastrografin enema. Surgical treatment is rarely required. Right iliac fossa mass, constipation in CF children is distal intestinal obstruction unless otherwise proved. Hepatobiliary symptoms is as common as pancreatic insufficiency. While the child crosses more than 5 years, palpability of liver and spleen is mandatory. A firm liver indicates the child is going for cirrhosis. A palpable spleen indicates that the child is going for portal hypertension. That's why after 5 years, the child has to be followed periodically. You need to do a clinical examination. You need to do a LFT. At times, in case of deranged LFT, you might go for and search for an evolving esophageal varices with the endoscopy. When there is a deranged LFT, you need to consider also deoxycholic acid 10 milligram per kilogram per day, twice daily. Remember, as I told you already, neonatal cholestasis with obstructive jaundice can be a manifestation of liver disease in CF, but that aids in diagnosis of CF, but there is no role for any treatment in those instances. It resolves on its own with simple IV fluids. Remember, cirrhosis with portal hypertension as the child grows will come if it is not properly given lipase treatment, not properly given not properly given hydration as well as enzyme replacement therapy, right? Nasal polyp is not that common when compared to adults. This is very, very uncommon in pediatric age group. If it is troublesome, you can give a trial of mometasone nasal spray for 8 to 12 weeks. If it is more troublesome despite mometasone, you can try removal with the help of an ENT surgeon. Sinusitis is often radiologically present. 100% radiologically all children will have. But symptomatic sinusitis present only in 1% children. For the an antibiotic course of 3 to 4 weeks is mandatory. And others, hemoptysis, streaky hemoptysis suggests that you need to treat infection. Hemoptysis is a manifestation of infection. But when hemoptysis becomes massive, more than 250 or more than half of the cup, that it indicates that there is an underlying bronchitis and this bleed is from bronchial artery. Apart from proper control of infection, you need to do bronchial artery embolization. But please rule out whether there is a vitamin K malabsorption. Please rule out whether there is an underlying deranged LFT before considering bronchial artery embolization. Oxygen therapy is indicated particularly in children who developed hypoxia whose PO2 is less than 50%. If there is nocturnal desaturation, if there is an exercise intolerance, if the PO2 is less than 50, if there is hypoxia alone, the child can be given oxygen therapy with the oxygen cylinder or oxygen concentrator. But if there is CO2 retention, you need to give BiPAP along with oxygen. So this is all about some of the other organ involvement in cystic fibrosis.